Today's topic is hip joint. Hip joint is a very important joint, synovial joint in the body because of its high mobility and directly proportional stability. Unlike many other joints, especially glenohumeral joint in the body, that is highly mobile, but its stability is actually inversely proportional to its mobility. Hip joint, what makes it more stable, even though it is one of the highly mobile joint, just like shoulder joint, there are some factors that are related, that are provided to the hip joint, but they lack in the shoulder joint. So first of all, let's see a few points regarding with the introduction of the hip joint. Hip joint forms the connection between the lower limb and pelvic girdle. This point is important because this connection, which is present in the form of hip joint, transmits the weight of the head and neck, thorax, and abdomen pelvis during the standing position to the head of the femur and neck of the femur via hip bone. So this connection is important in the form of hip joint, making it one of the weight-bearing joints of the body. Next, we have this joint, which is actually a very strong joint, even though it is multi-axial in mobility, but still it is a stable joint. Unlike glenohumeral joint, after which it is considered to be the most mobile joint, glenohumeral joint has instability related to its movements, but hip joint basically has not only high range of movement, but also higher degree of stability, unlike shoulder joint. This range of mobility and stability, they are of higher degree, unlike other joints, especially glenohumeral joint, specific to the hip joint. Why? Because number one, there is adaptation of the acetabulum and femoral head to each other. Femoral neck is long, much narrower. Femoral neck is longer and narrower as compared to the head of the femur, leading to the greater range of mobility. So it is a unique joint in the sense that it not only has a higher range of mobility, but it also is provided with the higher degree of stability, which is in contrast to the glenohumeral joint, that is shoulder joint. So what type of joint is hip joint? It is multi-axial synovial ball and socket variety of joint. Synovial because it has a cavity, multi-axial because its range of movement, they occur on various axes, and ball and socket depending on the shape of the articulating surfaces, with acetabulum forming the socket and ball is formed by the head of femur, which fits into the acetabulum. Articulation involves two bones, acetabulum proximally and head of femur distally. Let's see, or let's discuss some points related with the acetabulum. Proximally, it forms the articulation for the hip joint. It is itself formed by the union of ilium, ischium, and pubis, and is located on the lateral aspect of the hip bone. It is hemispherical, cup-shaped, hollow fossa or depression on the lateral aspect of the hip bone. It is divisible into at least three parts: articular part, non-articular part, acetabular notch, and labrum, along with the transverse acetabular ligament. So if you look closely in this diagram on the right side of the slide, this is the acetabulum, the cup-shaped hollow depression on the lateral aspect of the hip joint. It has a lunate shaped articular surface which is covered by the articular cartilage of hyaline in structure. Secondly, it has a non-articular part in the almost center of the acetabulum. It is called acetabular fossa, which is filled with the acetabular pad of fat, also called Haversian pad of fat. This acetabular fossa is basically formed by the ischium. It is very thin, to some extent being translucent. This fossa, along with the lunate surface, is deficient inferiorly in the form of acetabular notch, which is covered, converting the notch into a tunnel by the transverse acetabular ligament. The margin of the acetabulum is covered by the acetabular labrum, which is fibrocartilaginous in structure, and this labrum is there to provide the or to increase the depth of the acetabular socket to receive the head of femur. It is this acetabular labrum which is continuous in the form of transverse acetabular ligament over the acetabular notch. So we can say that transverse acetabular ligament is basically continuation of the acetabular labrum. Next, distally we have head of the femur participating in the articulation of the hip joint. It is covered in its entire extent by the hyaline cartilage forming the articular cartilage, except for almost in the center where the articular cartilage is deficient. And this center is marked by the presence of a small depression called fovea or pit, to which is attached the ligamentum teres or the ligament of the head of femur. This part of the femur is also non-articular in nature. Now moving on to the capsule of the hip joint. Capsule of the hip joint comprises of two layers, an outer fibrous layer which is quite thick with spirally arranged fibers, and few of them are circularly arranged. On the inner side, the capsule has synovial membrane. The outer fibrous external layer of the capsule is proximally attached to the acetabulum, peripheral around the labrum, as well as transverse acetabular ligament. Distally, the fibers, they spiral from the acetabulum towards the head and neck of the femur, so that anteriorly they reach the neck of femur, getting attached over the intertrochanteric line as well as root of the greater trochanter. But posteriorly, these fibers, they do not reach up to the intertrochanteric crest, but remain proximal to it, getting attached over the posterior aspect of the neck of femur. Here, these fibers, some of their deep fibers of the capsule external layer, they are circularly arranged instead of arranged spirally, leading to the formation of an area called orbicular zone or zona orbicularis. So these circular fibers, they are the deep fibers of the capsule of hip joint encircling the neck of the femur. After reflecting the fibrous capsule, we can see the synovial membrane, which lines the internal side of the capsule and the cavity of the hip joint. So, synovial membrane proximally is attached over the acetabulum, margins of the acetabulum, and reflects distally along the neck of the femur up till the edge of the head of femur as longitudinally arranged fibers called retinacula. So this retinacula can be considered fibers of the capsule blending with the fibers of the synovial membrane internally, and these are the longitudinally running fibers called retinacula. Their significance lies in the fact that these fibers provide passageway to the same named arteries, which are called retinacular arteries, branches from the trochanteric anastomosis, entering the cavity of the hip joint to supply blood to the neck and head of the femur. Which is why the fractures of the neck of femur, they are of great clinical significance, because in case of fracture of the neck of femur, these retinacular arteries, they will be disrupted, leading to avascular necrosis of the neck and head of femur, intracapsular part of the upper end of femur. Now you must be wondering that what about the branch from the obturator artery that enters the head of the femur through the ligamentum teres? That artery is believed to be patent during the childhood, but later in life, it is obliterated. So it actually becomes of least importance in the adults, but it is of great clinical importance in the children. Now you can see in this diagram that ligamentum teres is actually the reflection of the synovial membrane from the pit or fovea over the head of the femur till the acetabular fossa of the acetabulum. So it is a fold or reflection of the synovial membrane over the pit or fovea of the head of femur up till the acetabular fossa of the acetabulum proximally. Now moving on to the ligaments of the hip joint, which are of great importance because they play a very important role or very significant role during the movements of the hip joint. So ligaments of the hip joint are divided into two categories: extrinsic ligaments and intrinsic ligaments. We have three extrinsic ligaments in the form of iliofemoral ligament, pubofemoral ligament, and ischiofemoral ligament, which are basically thickenings of the fibrous capsule of hip joint. And intrinsic ligament we have in the form of ligament of the head of femur or ligamentum teres. So let's see their attachments and significant points one by one, starting with the extrinsic ligament and iliofemoral ligament, which is considered to be one of the body's strongest ligaments. It is Y-shaped or triangular shaped with apex attached over the lower part of inferior iliac spine, running towards the femur and getting attached over the intertrochanteric line. It limits the extension of the hip joint while in the standing position. Pubofemoral ligament, which is in this diagram shown in green color, it is located anteriorly and inferiorly. It is proximally attached to the obturator crest of the superior ramus of the pubic bone, and distally it runs to get blended with the capsule of the hip joint. It not only helps iliofemoral ligament to limit the extension, but it also helps to limit the hyperabduction of the hip joint. Next, we have a weak ligament, which is called ischiofemoral ligament, which is posteriorly located. Proximally, it is attached to the postero-inferior part of the acetabulum, whereas distally, it blends with the zona orbicularis of the fibrous capsule of hip joint. And we just saw the attachments of the intrinsic ligament, that is ligament of head of femur, in the previous slide. Moving on to the relations of the hip joint. These relations of the hip joint are very important from examination point of view because they are commonly given in the MCQs. And they are one of the sources for the medical students regarding confusion in the relations of the hip joint. So anteriorly, we have psoas major muscle. Here we have iliopsoas muscle shown together. You can see that psoas major muscle separates the hip joint from the femoral artery anteriorly. Here we are seeing the femoral artery. Pectineus, here we have pectineus muscle. Pectineus is more medially located in contrast to iliopsoas muscle, which is located laterally. So pectineus is the muscle that separates the capsule of the hip joint from the femoral vein. Whereas femoral nerve lies in the groove between the psoas major muscle and iliacus muscle, tendon of the psoas and iliacus. So you can see that this neurovasculature, femoral neurovasculature, is separated from the capsule of the hip joint by iliacus, tendon of the psoas major and pectineus muscle. This anterior relation of the capsule of hip joint is commonly asked in the MCQs of the professional examinations. Superiorly, we have reflected head of the rectus femoris here and gluteus minimus laterally. So medially and superiorly to capsule of hip joint, we have reflected head of rectus femoris, and laterally and superiorly, we have gluteus minimus. Whereas inferiorly, we have the tendon of the obturator externus muscle passing beneath the capsule of the hip joint. Posteriorly, you can see that it is related with the piriformis muscle, the obturator internus with two gemelli, and quadratus femoris. All of these muscles, they are separating the capsule of the hip joint from the sciatic nerve posteriorly. Laterally and medially, the capsule of the hip joint blends with the iliotibial tract and forms the lateral wall of the pelvis, respectively. The medially, the lateral wall of the pelvis makes it closely related to the ovaries in the females. This relation is of great clinical importance because of the close association of the ovary along with the obturator nerve and vessels, as well as hip joint, because irritation of the ovaries in females will lead to the irritation of the obturator nerve that will be referred as pain in the upper and inner medial side of the thigh. This is often asked in the exam questions, not only in the first year MBBS, but also in the second year MBBS examinations. So this was all about the relations of the hip joint. Nerve supply, we have femoral nerve, obturator nerve, nerve to quadratus femoris. All of those nerves, according to Hilton's law, that are passing and supplying the nearby muscles of the hip joint. they will also give articular branches to the hip joint. Because most of these nerves also supply knee joint, so pain arising from the hip joint in case of its arthritis or other inflammatory conditions will be felt in the region of the knee joint because of the shared nerve supply. Blood supply of the hip joint is of great clinical significance because, as I mentioned earlier, that in adults, the neck and head of the femur, they receive their blood supply from the retinacular arteries, which arise as branches from the trochanteric anastomosis. So in adults, if in accidents the neck of femur gets fractured, this will lead to the disruption of the retinacular arteries, leading to the loss of blood supply to the neck and head of the femur, leading to a clinical condition called avascular necrosis. Secondly, artery of the ligamentum teres, which is a branch from the obturator artery of variable size, is most of the cases patent in children, but in adults it is said to be obliterated. So it becomes of least importance in adults, but it is of great clinical importance in the children. Moving on to the final topic in the hip joint is the movements of the hip joint. Since it's a ball and socket type of synovial joint, this shape of the articulating surfaces, ball and socket, allows hip joint to perform various movements like flexion, extension, abduction, adduction, medial rotation, lateral rotation, and combination of movements called circumduction. In flexion, if you can see in this diagram, flexion of the hip joint, the surface of the upper surface or the dorsal surface of the thigh comes into contact with the ventral surface of the abdomen and pelvis, hence limiting the flexion of the hip joint. It takes place along a transverse axis and is carried by psoas major and iliacus muscles, assisted by the rectus femoris, sartorius, and pectineus. Extension of the thigh at hip joint is simply the extending the flexed thigh back to the normal position. Also takes place along the same axis, that is transverse axis, and is performed by the gluteus maximus and hamstrings. So in the initial stages, it is the hamstrings, and in the later stages of the extension at hip joint, it is the gluteus maximus performing or making these movements. Extension is limited by iliofemoral ligament. Adduction and abduction of the thigh, here in this diagram in the middle, these two movements take place along an anteroposterior axis and is carried out by pectineus, adductor longus, adductor brevis, and adductor magnus, as well as gracilis. It is not only limited, if we talk about adduction, limited by coming into contact with the opposite leg, but also the tension from gluteus medius and minimus also helps limit the adduction. Whereas in case of abduction, which is produced by gluteus medius and minimus, receiving assistance from tensor fascial lata and sartorius. This abduction is basically limited by the adductors. So we can say that abduction is limited by the tension in the adductors muscle and pubofemoral ligament as well. In sitting position, if the person is sitting on a chair, piriformis, the two gemelli and obturator muscles, all of these muscles, they act as abductors. For example, when you come out of the car, the leading leg that you put out of the car, that movement at the hip joint is carried by the piriformis, the two gemelli, as well as obturator muscles. Rotation, lateral and medial, they take place along a longitudinal or vertical axis. Medial rotation is performed by the anterior fibers of the gluteus medius and minimus, assisted by the tensor fascia lata. This movement, medial rotation, is limited by the lateral rotators and ischiofemoral ligament. Whereas lateral rotation is conducted by piriformis, obturator internus, gemelli, quadratus femoris, and obturator externus, assisted by gluteus maximus and sartorius. This movement, lateral rotation, is limited by the medial rotators, the tension in the medial rotators, as well as iliofemoral ligament. So this was all about the movements of the hip joint. Now let's take a look at some factors that may affect the stability of the hip joint. As we studied during the start of the topic, that hip joint not only is a highly mobile joint, but it is also considered to be quite a stable joint, unlike glenohumeral joint, which is considered to be body's highly mobile joint, but at the same time, it is unstable joint. So unlike shoulder joint, hip joint is not only highly mobile, but also has got a higher degree of stability. So the stability factors that affect the hip joint include atmospheric pressure, in which negative pressure inside the joint matters. Then shape of the articulating surface. You can see that the articulating surface, that is the acetabulum proximally, is cup-shaped, hollow depression on the lateral side of the hip bone that is further deepened by the presence of the acetabular labrum, so that the spherical head of the femur may get fit into the socket of the acetabulum. Then direction of the femoral neck. Femoral neck is actually very narrow as compared to the head of the femur. And this narrow neck, presence of the narrow neck in the upper end of the femur, provides more mobility, greater range of mobility to the hip joint. Capsule of the hip joint, though it is considered to be loose, but it is yet very strong, along with its extrinsic ligaments in the form of iliofemoral, pubofemoral, and ischiofemoral. And then we have muscles that surround the hip joint, like piriformis, obturator internus, the two gemelli, superior muscles like reflected head of the rectus femoris, as well as gluteus minimus. And below, we have tendon of obturator externus. So you can see that all of these factors They were lacking in the shoulder joint, but they are present and provided to the hip joint because of its weight bearing importance and weight transmission importance. It needs to be stable. So let's see some clinicals associated with the hip joint. We have avascular necrosis, which we just discussed earlier. Dislocation. Posterior dislocation of the hip joint is much more common than the anterior dislocation. But dislocation overall is very uncommon, but it may take place depending on the severity and extent of the blow to the or damage to the hip joint. Then we have surgical hip replacement. This procedure is common among the elderly that suffer from osteoporosis, and they are prone to easy dislocation of the femoral head from the hip joint, and they may require surgical hip replacement. So in other cases of osteoarthritis, in which there is inflammation and irritation and collection of the fluid in the hip joint, leading to erosion of the articular cartilage covering the articular surfaces of the femur and acetabulum. What surgeons do is, in that condition, they put a metal prosthesis that is anchored to the femur, replacing the head of the femur and neck of the femur. And to replace the acetabulum, they implant a plastic socket attached to the hip bone. So both proximally and distally, the articular surfaces are replaced by metallic and plastic prosthesis to give stability to the damaged joint as a result of inflammation of the joint called osteoarthritis. So this was all about today's topic. I hope you got a very good understanding. And this topic is given quite in detail in the textbook of anatomy by Keller.